All right.
All right. Thank you so much, Dr. Kweki. Thank you so much, everyone. Thank you for coming in for today's guideline review. Dr. Kweki will be taking infective endocarditis guideline review. He's going to have 30 to 35 minutes for presentation. Then we'll have interaction till the end. We have 1 hour for this session. So, Dr. Kweki, thank you so much for taking our time to make such an excellent presentation we're about to go through together. Thank you so much, sir.
All
So
right,
the floor is
thank
yours.
you. Dr. Kopi, thank you. And every other person, thank you. Like he said, we are going to spend about 35 minutes there about so that we can have some time to discuss. It's a long slide, have up to 78 slides, but I'm just going to pick the main points so that we can leave the other part for discussion. Okay, so to do that under this outline, like you know already, I'm going to be discussing infective endocarditis. Just have this case scenario. We had at the hospital a 68-year-old gentleman that came with fever and lethargy for about 5 days. He had past medical history of type 2 diabetes, hypertension, and some other vascular complications, such as amputated second toe. Examination was actually fine, but when we did the vital signs, the heart rate was over 100, blood pressure was elevated, there was tachypnea, SpO2 was about 93% on room air, and it was febrile with temperature of 38.9. The CRP was elevated up to 300. EGFR was fine. Creatinine was 91. Had hyponatremia of 121, and the hemoglobin is about 118. Pardon me, we use hemoglobin over here, over PCV, but so lactate was 1.4, blood culture was positive for Staph aureus, ECG was sinus tachycardia. So this is what the gentleman presented with, and the fact that is diabetic and had amputation in the past, came with fever, and then temperature of more than 38 with positive blood culture of Staph aureus. So we got the referral to see if we could rule out possible infective endocarditis, especially now that the patient had fever and had positive blood culture for a typical organism, which is Staph aureus. And as we know, that can be, the organisms could be very virulent. So for that reason, we got the referral to do transesophageal echo and see if there's a vegetation in the heart, and that could be responsible for the infection that is ongoing. So when we did the transesophageal echo, of note is that we first of all did transthoracic echo, which came out to be negative. There was no findings on the transthoracic echo, but because he was still spiking temperature and the fact that he was positive for Staph aureus, so we're a bit concerned. So we had to go further to do transesophageal echo. When that was done, this is the image. I'll try and play the video for us and see if we can just watch it for a few seconds. So this was the image we found on transesophageal echo, a very huge vegetation on top of the mitral valve, on the atrial aspect of the mitral valve. So this is just one of the section. But if you look at the full section, including 3D images, which is not here, you could see that the clot was so large such that it transversed the mitral valve into some part of the left ventricle. So it was a huge vegetation. So because of this, and with the fact that he was already on antibiotics, was not getting better, so had to refer to another center for surgical intervention. As we all know that if you have a large vegetation, is an indication for surgical intervention because the risk of septic embolism is high and mortality is also high, especially on the background of staph oral infection. They tend to present with a lot of microabscesses to the brain, to the lungs, and different parts of the body. So that was the reason why we had to refer him to another a cardiothoracic center where surgery was done for the gentleman. Okay, so just by way of definition. So sorry, my slides is a bit messed up. Sorry, let me change this. Okay. So just by way of definition, I've said that infective endocarditis is an infection of the endocardial surface of the heart, which may involve one or more valves, or the endocardium can be involved in cases of where you have septal defect. That can also be involved. And sometimes, if nothing is done on time or at the immediate state, sometimes patient can present with some severe valvular insufficiency. It could be any of the valve, mitral regurgitation, aortic regurgitation. Patient can come with congestive heart failure, cardiac abscesses. And then they can also have some extra cardiac complications, which include pulmonary septic emboli, brain abscesses, and including renal artery infarcts. Then they can have infarction involving the peripheral vasculatures, depending on the extent of microembolization. So I think this slide is not, we shouldn't be here, but okay. So just talking about some of the epidemiology, it's still a major problem. What you have noticed is that I'm seeing more of infective endocarditis right now in the UK compared to the cases I saw back at home. In fact, maybe one or two cases I saw in Nigeria, but here it's quite of a problem. So I'm not sure of the reason why they tend to have a lot of it here. Probably we take a lot of antibiotics for anything, so that probably would sometimes treat the infection before it gets to the advanced stage. But over here, antibiotics stewardship is a major campaign. So you can't just go to the pharmacy or anywhere to have access to antibiotics. So they tend to have a lot of them, and it's a major problem. Mortality is very high if it's not addressed on time. So it's up to 30% in 30 days. And we tend to have a lot of them. So it's a major issues, and it's always good to address it as fast as possible. So this is just a way of classification. I'm sure we know all this. I won't spend my time on this because sometimes acute and subacute are very important. Is the fact that when you have IE related to a prosthetic valve, you need to be very aggressive with the care. If not, the patient will have to undergo another surgery. So just talking about native valve endocarditis in Africa and West Africa in particular, it tend to evolve as part of rheumatic valvular heart disease tend to be one of the risk factors. Other risk factors include congenital heart diseases, which include VSD, TOF, or PDF. And sometimes over here, degenerative heart disease tend to be a major problem. And that can be a valve that is already damaged. And once the patient have bacteremia, it becomes a good environment for bacteria to grow. Then you still on native valve endocarditis. It could be acute problem. It could be subacute problem. Acute cases tend to be due to staph aureus, like the case we saw previously, where the gentleman, 68 years old, diabetic, the vegetation was very large. So that's what acute bacterial endocarditis tend to be very virulent. And then if nothing is done, they tend to cause a lot of metastatic septic infections to distant organ. They tend to be destructive, and they can involve normal valves, and it can also be seen in individuals that are involved in drug treatment. And if nothing is done, mortality could be very high within few seconds, within weeks. Subacute bacterial endocarditis tend to involve alpha hemolytic streptococci or enterococci of low virulence. So these tend to present with low virulence compared to those that occur in acute bacterial endocarditis. Of importance is the issue of prosthetic valve endocarditis. We don't want that to happen. So it's always important for us to be a bit careful, because after putting a valve in a patient, for a patient to have an IE from whatever reason, it means that you have to take the patient back to the theater, open up the heart. Especially if antibiotics is not giving you the response you want, you have to take the patient back to surgery and see what you can do, either remove the valve, implant another one. So there's a whole lot of issues. So you want to be very careful. There are two ways that can happen. Those that happen within the first 2 months of the surgery, and tend to be due to the coagulase negative staphylococcus aureus. Examples is the staph epidermidis. It tends to occur within the first 2 months. And usually it's said that these occur as a result of contamination during the surgery. So that's why aseptic procedure is something that we don't play with. It's very important, because if you don't do that, patient can come down with infections and mortality could be very high. But if it occurs more than 2 months, it tends to revert back to the most common organism in IE, which is Staphylococcus aureus. So if it occurs within 2 months, it's due to coagulase negative staph aureus, Staphylococcus, which is basically Staphylococcus epidermidis. But anything more than 2 months tend to be due to Staphylococcus aureus. And for intravenous drug abusers, Staph aureus is still the most common organism. For head-related endocarditis, Staph aureus is still the most commonest, but you can also see Staph epidermidis, like I said earlier on, usually for those that undergo surgery. For whatever reason, there can be contamination. Then you can also have a situation where culture for IE could be negative. There are a lot of reasons for that. Could be because you started antibiotics before you collected your blood sample, or you could have organisms such as Coxiella bonnetti, Bartonella species, Chlamydia species, or the Hassett root of organisms. It's also possible that it could be fungal infection, long incubation period. It could be non-infective from a trimizoma or marantic endocarditis. Please, if you're just coming in, happy for you to just mute your mic so that you don't distract the lectures, please. Thank you so much. Sorry, this thing is not moving again. So what are some of the risk factors? Talked about some of these ones, but just to also make us understand that the most important signal risk factor for IE is residual valvular damage caused by whatever reason, either background calcific changes on the valve, or may have had a previous attack of endocarditis that have destroyed the valve. Now the patient now have bacteremia for whatever reason, and that can predispose the patient to having an infection. So for those that are taking intravenous drug, or those that have prosthetic valve, or those that have congenital heart diseases, these are all risk factors for IE. Part of the world, like our country, rheumatic heart disease is a major risk factor. Then you have some other host problem, like those that are neutropenic, immunodeficient, malignant patient, diabetic, like the patient I presented as a case study is a known type 2 diabetes. So that is one of the risk factor in that patient. So this is, again, just to highlight some of the risk factors I've talked about, cardiac and non-cardiac. It's important for us to take note of the non-cardiac risk factors, such as central venous catheterization. And in fact, staph epidermidis has been known to be a common organism that colonizes central venous catheter. And that can become a risk factor for such individuals. Those that are going through hemodialysis, they could develop bacteremia as a result of aseptic procedure. So all of these have to be well taken care of. Of important is cardiac devices. You don't want your cardiac device to become infected. So you need to take a whole lot of aseptic procedure when you are trying to implant any cardiac device. For those that are going through valvular heart surgery where they have to receive prosthetic heart valve, you need to be very careful of how you maintain aseptic procedure. In fact, most of the patients that are worked up for valvular heart surgery, you have to be sure that they are methicillin resistant staph aureus negative. And sometimes, even if they are negative, you have few days before the surgery, for about 5 days, about 10 days, you have to give them Bactroban. Okay, Bactroban, it's an intranasal spray where they have to apply all that on the nose and be sure that they don't have any residual organisms that have become a source of infection to the prosthetic valve. Or we'll also give them Otanicin. Otanicin, it's a kind of Savlon or chlorhexidine, where they use in bathing about 5 days before the surgery, so that any organism colonizing the skin, such as the staph epidermidis, such organisms can be sterilized, can be taken care of, or their body can be completely sterile of any organism before the surgery. These are all procedures that are put in place to reduce risk of infection for whatever reason. So this is just pathophysiology. I have a very simplified stuff to that, so that may just keep some of this on because of time. Turbulent blood flow is a major pathophysiological process, and that can damage valve surfaces. And once that happen, it will lead to platelet depositions and all the pathophysiological processes. And usually you could have a thrombus or have a platelet deposition, but if there is no source of infection, or if there's no bacteremia, it could usually become not bacterial thrombus or vegetation. But once the patient develops bacteremia for whatever reason, this organism can become sticky to these endothelial surfaces, and that will lead to colonization and further worsen the process. Eventually, it's going to lead to inflammatory reaction and all the problem we see in this individual. So factors that facilitate the entry of organisms into the bloodstream, this may include the following: poor oral dental hygiene. So this is one of the reasons also why when we are preparing a patient for valvular heart surgery, you have to be sure that the teeth are fine. In fact, one of the things we do is to refer the patient to the dental surgeon for proper checkup. Be sure that they don't have any dental caries before the procedure is done. And if they have, it has to be treated because some of those organs can become a source of infection, and that can affect the valve. Then iatrogenic causes of bacteremia could be any procedure where you have to do dental treatment, especially where you maneuver the gum or the mucosa of the oral cavity. That can become a source of bacteremia. It's been said that for plaques, those plaques on the teeth is a very good area where bacteria tend to reside. So when you maneuver the buccal mucosa, some of these bacteria can be transmitted into the systemic circulation, and that can become a source of bacteremia. And if there's already background valvular problem, it could cause an infection. And if the organism is virulent, it doesn't have to even need any destroy valve for that to happen. It can affect the native valve. Okay, so that's the reason why they said anybody that's going for dental procedure where you have to receive mucosa maneuver, especially if the patient have cardiac risk factor for any of these defects, you will have to give the patient antibiotics prophylaxis. So there's also some other group of conditions where we said they are non-bacterial thrombotic endocarditis. I will send the slide to us so we can look at it, but because of time, I just want to move forward. This is what I've just explained so far. You can look at it once you get the slides. Then just to highlight that some of the organisms are common in the mouth. So these are the hemolytic viridans streptococci, which include the strep, mutas, strep, sanguinis, and all the rest. So these are organisms. Once you see these organisms in any patient, you need to look at the mouth and be sure that the mouth is not the focus for some of these organisms. Prolonged hydraulic catheter, another problem. Talked about IV drug user before. The guts and perineum. Very important is when you see a patient with strep bovis or strep galoticus. Okay, once you see any patient with that organisms, you need to be sure that the patient does not have colorectal CA, because patient that have strep bovis has been shown to also have alongside with IE pulmonary CA. So most time for patients that have strep bovis positive blood culture, you need to request for colorectal CA. Be sure that that's not the source of the bacteria. And if you do your colonoscopy and is normal, you need to look at the biliary tree. In that case, you need to do MRCP. That's a magnetic resonant cholangiopancreatography, something like that. So you need to do that to be able to outline the biliary system, be sure that the organisms is not coming from the biliary system. So these are some of the rare causes. We know all these. These are some of the symptoms. I'm sure we're conversant with all these. These are things you can see in the patient that have some of this condition. For skin manifestation, they could have the Osler's nose, splinter hemorrhage, Genway lesion, petechia. On the eye, they should have rust spot, conjunctiva, splinter hemorrhage. These are some of the things to suggest septic embolization. Okay. So they could also present with splenomegaly, neurological problem on the renal system. They could have hematuria as a result of septic deposition on the glomerulus, and that could lead to hematuria. How do we make diagnosis? Blood culture is important, echo is important, ECG important, but not diagnostic. But in a patient with IE, and ECG is usually one of the tests you use to monitor the patient, because for individuals that have aortic abscess, one of the things they present with early is prolongation of the PR interval. So if you do your serial ECG and you see that there is progressive prolongation of the PR interval, it suggests to you that probably there's an ongoing aortic abscess. So you need to take further decision on that. So blood culture, if endocarditis is suspected, through blood culture, about 20 ml should be taken at most within 24 hours. But if you think that the patient have acute bacterial endocarditis, okay, so you have to do that between 1 or 2 hours apart, because you need to do that immediately for you to have a to be able to isolate the organisms and then look at possible antibiotics that are susceptible to the organism. So if patient is suspect that this is acute bacterial endocarditis, you take at least 2 blood culture within 1 to 2 hours apart. Usually what happens in the hospital is that once anybody just come to the hospital and you suggest the patient to have IE, you have to take about 2 blood culture within 1 to 2 hours apart. Okay, so that's usually what we do, especially once in this part of the world where most of the presentation tend to be acute bacterial endocarditis, because they're usually antibiotics naive. You can't get antibiotics from anywhere. So they tend to come with the usual presentation, the fever, and all the rest. But in places where this is not the case, that might not be the approach. But usually what we do at the hospital is to make sure that you get about 2 blood culture within 1 to 2 hours for you to have a microbiological diagnosis of the organisms. It is good for you to give antibiotics quickly to the patient, because that has been shown to improve morbidity and mortality. But you must be able to compare collecting your blood culture before before you give your antibiotics, because it's always good to isolate the organism for you to look at susceptibility. Anyway, when you talk about the diagnosis, blood culture is one of the criteria anyway. So it's always important for that to be done. At least where I work currently, you are able to collect blood sample before antibiotics, because there are protocols from emergency down to the ward. In fact, once anybody presents with fever, you're going to collect blood culture anyway. So most time, blood culture is already done before antibiotics is started. So it's always good to collect your blood sample before you commence on antibiotics. So these are other bloods that can also be collected. I'm sure we can look at all these. These are things that we are quite familiar with. So echo is important. Transthoracic echo is still the first line, but you may need to do transesophageal if the patient got prosthetic valve, intracardial complication, inadequate transthoracic, or you have culture negative effective endocarditis. In some instances, it is said that transthoracic echo is just adequate if it's able to give you all the information you want. Otherwise, even if transthoracic echo has been done for the patient, it is recommended as part of the guideline for you to also proceed with transesophageal echocardiograph, because it helps you to be able to quantify the extent of the disease. Because sometimes the approach to the care of the disease is not just antibiotics. There are clear indications for surgery. And some of these clear indications for surgery may not be accurately delineated if you depend solely on transthoracic echocardiography. So for some of these reasons, for patients that have positive transthoracic echocardiography, they may as well go ahead to do transesophageal, except the cardiology or the doctor managing decides otherwise. So this is just part of the guideline. We can see that it is 1B, 1B recommendation for transthoracic echo to be done as first line imaging in all patients that are suspected with IE. I understand that this statement probably, it should make a whole lot of sense because, again, most time the first stuff we want to do is transthoracic echo. But I can tell you that based on my experience right now, what we usually say is that patient comes to the hospital, have positive blood culture for staph aureus, and the next referral we get is that we should come and do transesophageal echo for the patient. Meanwhile, transthoracic echo has not been done for the patient. So this statement makes a whole lot of meaning to me because these are some of the things we see every day. But in a setting where you don't even have transesophageal echo, it's going to be transthoracic anyway. But in advanced centers, other medics, they tend to refer patients to the cardiology unit for transesophageal echo to be done. So the guidelines still recommend that transthoracic echo should be the first imaging modality if you suspect IE. Okay, then TOE is recommended in all patients with clinical suspicion of IE and negative or non-diagnostic TEE. So again, like I said before, TOE is still recommended in all patients. The moment you suspect it, you should do it. Or even though the transthoracic echo is negative, and you still think that as a clinician that there's high index of suspicion for this patient to have endocarditis, then you have to go ahead. The only reason probably you don't have to do TOE is because you think that the transthoracic echo is sufficient enough for the care of the patient. Otherwise, all patients with effective endocarditis should do TOE. So TOE is also recommended in patients with clinical suspicion of IE when a prosthetic heart valve or an intracardial device is present. So repeating transthoracic echo and or TOE within 5 to 7 days of management is recommended in cases of initial negative or inconclusive examination when clinical suspicion for IE remain high. TOE is recommended in patients with suspected IE, even in cases with positive TTE, except in isolated right-sided native valve IE with good quality transthoracic echo examination and unequivocal echocardiographic findings. I think that's what I have been saying all along. Then it's also said as per follow-up under medical therapy. So once the patient has been admitted to the hospital, have received antibiotics for a while, so this has to do with the follow-up. So repeating TE, transthoracic echocardiography or TO is recommended as soon as new complication of IE is suspected, such as new murmur, embolism, persisting fever, bacteremia, heart failure, abscess, or atrioventricular blood. So while the patient is on admission, receiving antibiotics, and then you find out that the patient developing new murmur different from what it was before, or maybe patient had no murmur, there is now murmur now, or patient had septic embolization in the form of septic embolization to the pulmonary circulation, brain abscess, or to the distal part of the body. Once you pick anything like that, or there's a persistent fever, despite being on regular broad spectrum antibiotics, you want to repeat either transthoracic echo or TOE for the patient. Most time we would love to go for TOE because it tends to give you a better delineation of the valve. And it's a class 1B recommendation. TOE is also recommended when patient is stable before switching from intravenous to oral antibiotics therapy. So there are some times where you've completed your antibiotics regimen, okay, for about 4 to 6 weeks, depending on the type of infection you are dealing with, and you're happy for a patient to go home with oral antibiotics, you will need to check the valve again and be sure that there is nothing to suggest high risk and the patient is just okay to go on with oral antibiotics. So during surgery, usually there's a concept of intraoperative echocardiography, and on completion of therapy is also advisable for the cardiac and the valve morphology and function be properly evaluated. So TOE are recommended at completion of antibiotic therapy for evaluation of cardiac and valve morphology and function in patients with IE who did not undergo heart valve surgery. So usually what we do is that at the end of the completion of the antibiotics, we tend to repeat the blood culture, repeat the inflammatory markers to be sure that they are all coming down, blood culture is negative, and then repeat the TOE and be sure that it's clear of any vegetations that was there ab initio. So diagnosis, usually deduce criteria. Sure, we are all familiar with all these, more than at least 2. So these are just the major criteria of importance I want to really talk about is the concept of other imaging modality. I've talked about extensively on echo, either transthoracic or transesophageal. But sometimes you are unable, for whatever reason, to be able to do your TOE, either because the patient is not cooperative, either because the patient is not the best candidate to be able to swallow the probe, or patient refuse to do the procedure anyway. In those instances, okay, so we need to just mute that person. In case of instances where patient refuses TOE because they don't want anything to be stuck into their throat, you can do other imaging modality, which are the cardiac CT, can do the PET or the SPET scan. Of useful to us is the idea of the PET scan, is able to localize the site of infection. If there's an infection around any of the valve, is able to tell you exactly that there's increased uptake of the glucose around that area. So that suggests an infection. Sometimes cardiac CT is very helpful because beyond just helping to localize the infection, is able to tell you the size of the aorta, especially if you're dealing with aortic IE, and then can tell you whether there is aortic abscess or not the rest. But PET can go further to also delineate distant involvement. So I said I got the law. Let me try to round up. We all know this. We know all this. This is what I've said so far. Cardiac CT is recommended in patients with possible native valve native valve IE to detect valvular lesions and confirm the diagnosis of IE. And I've said that already. These are splinter hemorrhages. This is Osler's nodes. You can look at it once you get the slide. This is rod spots. Treatment is basically supportive, which I'm sure we're all aware of. But the mainstay of treatment is antibiotics. That is a mainstay of treatment. Always good to involve other teams like the microbiology, the cardiology, the pharmacists, the infectious disease, especially in fact, in centers where they treat infective endocarditis, you tend to have the infective endocarditis team, and it's made up of all these guys I just talked about. You need to treat them for about 4 to 6 weeks. And surgery, it's also an option. And these are some of the indications for surgery. Still, the indication for surgery: myocardial abscesses, progressive heart failure. These are the member of the infective endocarditis team. I just talked about the cardiology, cardiac images, and all the rest, as you can see right there. So this is also an approach as per the guideline. I got this from the guideline, and it just tells you what happened with patients that come to the hospital and the response, and when you need to alert the cardiac surgery team, or when you need to treat medically. Again, this also tells us about phases of antibiotics. The most critical part of your antibiotics is first 2 days. Critical part is first 2 days, and then you continue for about 4 to 6 weeks. So these first 2 days, you may need to perform TOE to be sure that things are getting better. If plenty markers are coming down, nothing to suggest an ongoing infection. Okay. These are also respond to patients that have complications. So we'll talk about monitoring. You can look at the slides once you're ready. These are some of the complications which we have talked about indirectly. Now, these are also as per guideline recommendation. What happens once you have heart failure? So it said emergency surgery is recommended for aortic or mitral valve infective endocarditis if there is features of heart failure alongside with is a class 1B recommendation. If you have uncontrolled infection, class 1B recommendation. If there's risk of embolism, especially once the investigation is more than 10, that patient I presented, investigation was more than 10, so we referred for surgery, because if they're more than 10, the risk of embolization is high. These are other recommendations. I think I've talked about some of these things. MRI PET recommended patients suspected spondylodiscitis and vertebral stomatitis complicating IE. So we can look at them once you get this slide. So these are also some of the recommendations. You can also look at them once you get this slide. So prevention is important. So preventive data examination and therapy before surgery or valvular heart repair is important, which I also talked about. Antibiotic prophylaxis. So this is very important for our exam. Prosthetic valve. Those that have prosthetic. So antibiotic prophylaxis are indicated for individuals going for dental procedure such that there'll be maneuver of the oral mucosa, and there's a background prosthetic valves, previous infective endocarditis, congenital heart disease, heart transplant recipient with valvulopathy. So any procedure involving manipulation on the gingival tissue or periapical region of the teeth or perforation of the oral mucosa, you have. Give it to mommy. I'm an So any procedure where you have to maneuver the valve and all that, I think I'm being signaled that I'm out of time. So we can look at all of that once you get the slides. Of important is that prophylaxis is no longer routinely recommended for GI or genitourinary procedure. Okay. So these are some of the guideline-based recommendations as per what I've said so far. We can look at them and also take some things from them. The same thing from here, So prognosis in developed countries, in-hospital mortality range from 15 to 22%. Independent predictor of mortality include higher age, staph aureus, heart failure, and any complication that arise during the treatment or the infection. So in conclusion, infective endocarditis is a potentially fatal illness. Thus, early diagnosis and treatment is vital in reducing morbidity and mortality. references. Thank you for listening. Thank you.
Wow, thank you so much, Dr. Kweki, for that extensive, excellent, and scintillating presentation. Thank you for the sacrifice. Going through the presentation, I could see how much work you did, in fact. For a very long time now, this is one of the most elaborate presentations I've seen in infective endocarditis. Thank you so much, sir.
Thank
So
you.
now the floor is open for contributions. You can use the electronic page in case you don't have anything to contribute. At least you can applaud the presentation. This is a landmark presentation on infective endocarditis, and we all know that for those going for exam, this is a high yielding area. It must come out. In our exam, it came out and a lot of stuff. So please, the floor is open for interactions, for debates, for contributions, especially for those going for exams and our fellows. You can raise your electronic hand and then we'll call you up. Or you can type on the page, I'll read it out. We have 10 minutes to do this discussion today. So the floor is open, please.
That time just worked. Now it's not working.
I don't know. Can you hear me? Can we all hear me, please?
We hear you loud and clear, Chief.
All right, please, let's raise our hands and contribute so that Dr. Kweki can give further insights to what he just presented. Meanwhile, Dr. Kweki, thank you so much. I was so interested in the aspect of the guideline with respect to antibiotic prophylaxis. If we've searched so far in the previous past exam, that's one area that we've seen a lot of questions that comes out and quite confusing. I don't know if you can throw more light on it from the guideline. And also monitoring recovery from treatment. I don't know if you can also say something about it. I understand you spoke about ECG. I also knew about hemoglobin, using the hemoglobin to monitor treatment, and some serological markers for monitoring improvement in treatment. I don't know if you can say something about this.
Okay.
Meanwhile, on the chat box, Dr. Ibe Kasibi is saying, thank you so much for an excellent presentation.
Thank you. Thank you. Okay, so thank you so much. So antibiotic prophylaxis is something that, like you said, this is a high yield and have a whole lot of interest. So the first thing we need to understand is that anybody going for dental procedure, okay, where you have to maneuver the gingival tissues, the maneuvering everywhere, removing teeth, that procedure where you have to cut through the gum and all that. So you're maneuvering the gingival tissues or the periapical region of the teeth or perforation of the oral mucosa, anyone like that, that person needs prophylaxis. That's the number one statement as per the guideline. Number two, anybody that is going through any oral procedure, not necessarily where you have to maneuver the gingiva or perforate the oral mucosa. You don't have to do any of such things. The first thing is that this group of people going for dental procedure, you're going to maneuver the gingival tissues, which maneuver the gums and all the tissues around, or you're going to perforate the oral mucosa or the periapical region of the teeth. Anything like that, give antibiotic prophylaxis. But for some certain individual, even though you're not going to maneuver, which are these individual on the slide, those with prosthetic heart valves, those with previous infective endocarditis, those with congenital heart diseases, or repair cyanotic heart disease, completely repair congenital heart disease during the first 6 months after surgery if prosthetic material or device was used, or repair congenital heart disease that has residual defects at or adjacent to the side of repair, or those with heart transplant. Any of these individuals, even though you're not going to maneuver the apical region or the oral mucosa, you still have to give them prophylaxis. Then any procedure involving incision in the respiratory mucosa. So where you have to do your bronchoscopy and you want to make some incisions here and there, they also need prophylaxis. Okay, procedure on infected skin or musculoskeletal tissue, including incision and drainage of an abscess. So, of course, they will also need prophylaxis, especially if they have those cardiac risk factors that we talked about. But if you have an individual that doesn't have any of those risk factors I just listed, all these ones, and then you're just going to do an oral procedure where you will not monitor, or you not manipulate or perforate the oral mucosa, you don't have to give prophylaxis. That's what everything is saying. So this is what the guideline is saying. So let me read each of the antibiotic prophylaxis recommended in patients on previous IE. We've talked about that before. The conventional antibiotic prophylaxis in patients with cardiovascular diseases undergoing oral dental procedure. So that's the point. Any patient with cardiovascular diseases, like what we just talked about, undergoing oral dental procedure, there's an increased risk of infective endocarditis. So the class 1B for someone that have previous IE to receive antibiotic prophylaxis. 1C for general precaution measures are recommended at risk of high risk or intermediate risk of IE. So I think it's just here. I'm just trying to make sure I keep to time. So antibiotic prophylaxis recommended in patients with surgically implanted prosthetic valves and with any material used for surgical cardiac valve repair. They're all class C. So this is what I've just explained in the previous one. So antibiotic prophylaxis is not recommended in other patients at low risk of IE, so which is 3C. This is also talking about prophylaxis. Antibiotics prophylaxis recommended in dental extraction, oral surgery procedures, and procedure requiring manipulation of the gingiva or periapical region of the teeth, which I've also explained. So I think just looking through all these will tell us exactly what we need to do. Then as per monitoring, so there is really this, I think I showed this flow chart, which was really nice. So this is usually, we said if the mainstay of treatment is antibiotics, which usually you either start empirically, but it's nice, a center where you have microbiology who makes part of the IE team. You speak to the microbiologists, they are usually there to advise you on what to do, because again, the blood culture that will be out, they are the first to know, because microbiology take charge of the lab. When the blood culture is positive, the scientists will let them know, they go through the patient. So they're going to give you a go anyway and give you advice on antibiotics to start. Okay, so once you start the antibiotics, the first 3 doses of antibiotics are critical. The first, second, 0, 1, 2, they're very important. So while the patient is receiving all this, you're doing your inflammatory markers, you want to be sure that everything are coming down, okay? You're looking at your ECG, like I said, progressive prolongation of PR interval, and temperature is also coming down. So if everything is coming down, that is great. So at about the 10th day of your treatment, usually you repeat your TOE, which again, we don't do routinely. We don't do it routinely because if all the fever is coming down, inflammatory marker is coming down, the NHS doesn't want to waste money to start doing another TOE. But ideally, in the centers like US where you can do anything you want because finances is not the problem, at the 10, repeat the echo just to be able to see the progression of the vegetation. Again, you want to be sure that you don't have abscess, the vegetation is not getting bigger, is resolving and all this stuff. So that's how you monitor. So after the third is when you're sure that the patient is responding to antibiotics, the rest they become continuation phase with treatment up to 4 or 6 weeks. 4 weeks is usually for native valve treatment. 6 weeks is when you are dealing with prosthetic valve. And usually after the 10 days, there's what we call OPAT. OPAT is a technique where you allow the nurses at the community level to take over the use of antibiotics. That is, the patient go home at day 10. If all these markers are showing that there's good response to antibiotics, you discharge the patient home. There's no risk of complication. You're not expecting any problem. Patient goes to his house. Then the nurses can go to the patient house and give the antibiotics for the remaining days of the week, such that you don't keep the patient in the hospital just because you want to give antibiotics. Thank you.
Wow, thank you so much, sir, for that elaborate explanation. Let me read the chat box before I call on our prof for further contribution. So I know so far nobody has raised his or her hands. I've not seen any. But Dr. Sorry Conte said, thank you for the beautiful presentation. He said, you mentioned that mitral valve position has the highest risk for prosthetic valve endocarditis, infective endocarditis. Is there any explanation for this? So let me just read the next question.
Yeah.
Yes. The next question is from Sani Abubakar. He said, thank you for a very lucid presentation. So what is the antibiotics recommendation in patient with prosthetic heart valve? Just to add to, what do you think about hemoglobin as a measure for monitoring improvement in treatment? Thank you, sir.
Okay, so the first question is that, well, I didn't really say that mitral valve position has the highest risk for prosthetic valve. If I said that, maybe it's a mistake. Now, prosthetic valve generally, they are risk factor. Okay, especially if there's contamination during the surgery for a patient coming down with early prosthetic valve endocarditis. Otherwise, if it's more than 2 months, it reverts back to the usual common organism, which is Staph aureus, and that is referred to as late prosthetic valve infective endocarditis. For concerning issues of which valve that is most commonly involved in patients that have infective endocarditis, we all know that the mitral valve, aortic valve, pulmonary valve, and then what's it called, tricuspid valve. But in my experience here, a lot of the stuff has been with aortic valve that are involved. Again, that could be that the most commonest valve that they have problem with over here is aortic valve because of degenerative aortic stenosis, which is also very common here. So if that is what you heard, I apologize for that. I wasn't trying to say that the mitral valve position has the highest risk of prosthetic valve IE. Okay, but the mitral valve is known as, is mitral valve, aortic valve, pulmonary valve, and tricuspid valve. Okay, then so the use of antibiotics generally for native valve native valve endocarditis, you want to give your amoxicillin-based medication. I'm surprised that here, amoxicillin is very effective. I'm sure, again, abuse of antibiotics is not so common. But the moment you are able to isolate organisms like Staphylococcus aureus, you want to change to your flukes. Flucloxacin is what we commonly use for treatment for Staphylococcus positive infective endocarditis. But if you're now looking towards things now, methicillin resistant Staph aureus. So apart from adding your fluklox, you want to include low dose rifampicin or gentamicin. Sometimes you want to take away the fluklox completely and start with vancomycin. For patients with prostatic IE, we just want to start with vancomycin rifampicin, and gentamicin. Most time we tend to shy away, even the microbiology, until if it's necessary, try to shy away from gentamicin because we know the complications that are involved in use of gentamicin, especially nephrotoxicity and ototoxicity. But again, we've been able to also handle that because sometimes, not sometimes, all the time, we do pre-dose treatment and post-dose level of gentamicin. So for pre-dose gentamicin level, just before you give it, take the level of gentamicin should be between 1 and 2. Okay, anything more than 2, it tells you that the level are too much and the risk of nephrotoxicity is high. So you may need to skip the next dose just to increase the space between the first dose and second dose. But if you do your post dose, usually should be between 5 and 10. So if the levels are more than 10, it tells you that your post dose level is too much. Okay, so if you may need to reduce the dose. Okay, but for whatever reason, if you are in a center where you have a good microbiology support, just speak to your microbiologist, who anyway is part of the team that take care of infective endocarditis. So from beginning, they'll be involved. That's their area. They'll keep telling you, keep it this way. If the patient is not responding, you call them, they can advise you. Sometimes, as effective endocarditis is not solely a cardiology problem, really. Okay, but I understand that in some environments, you are the only one that will address all issues. But if you're working in a standardized environment where you are not the only person, it's always nice to discuss with the other people, not just because you don't know what to do, but because of medical legal reasons. So they expect you to discuss with them and document accordingly. Thank you.
Thank you so much, Dr. Kweki, again. This is very pleasing response and very great presentation. Really, we apologize for going beyond our 1 hour, but please let's call on Prof for he's one of the moderators.
Somebody just me drop a statement here.
Okay,
Alex,
let me check. Okay, Alex, it will be. Okay. He said, thank you very much. Excellent presentation. Please, what is the recommendation for a patient plan to have colonoscopy as per antibiotics?
What is the recommendation for a patient plan to have colonoscopy as per antibiotics? I'm not so sure, but I would think that he's referring to.
Yeah, those the guideline for antibiotic prophylaxis. And you remember
No,
you
it's
said
not
for
recommended. Any GI procedure upper
any
or
GI
lower.
is not recommended.
And GI upper or lower endoscopy. You don't have to give antibiotics. It was
so
initially,
Alex,
but recently it's been removed as part of the recommendation. Even if you're go ahead.
Yes, and just for the sake of the exam, since he's going for the exam, it's one of the places they usually play around for the MCQ. So you should know it clearly that it's not recommended. Go ahead, sir. Sorry for the
So
interruption.
even for those doing bronchoscopy, the only time you have to do that if you're sure that you're going to breach the respiratory mucosa. Because in that instant, there's a risk of organism getting into the bloodstream.
Thank you so much, sir. And you also stated it in the slide. When the slides will be out, and Dr. Alex, you can also go through it. So thank you so much, Dr. Kweki, for a very beautiful and detailed presentation.
Someone said, which patient with benefit from oral what? I can't see that part.
Oh, I'm not seeing it. So, is that?
Dr. Pressure said, thank you, sir, and excellent presentation. Which patient would I benefit from oral step down antibiotics therapy or oral antibiotics medication as treatment? Again, the truth is that patient takes IV antibiotics for 4 to 6 weeks. Okay, so that's what the guideline recommend. 4 weeks for a native valve endocarditis, 6 weeks for prosthetic valve endocarditis. For individual that I didn't see in anywhere in the guideline where it was stated 1, 2, 3, 4, 5, 6, 7 can be oral step down. But I would think that that is dependent on the decisions of the clinician, especially if you have commenced antibiotics at the 10-day, patient has done well. Look at what at day 10, from day 10 post-treatment initiation and or 7 days post-surgery. Consider OPAT. OPAT means outpatient-based antibiotic treatment or oral antibiotic treatment in stable patients. So this word stable patient wasn't defined. What did they mean by stable patient? So I'm sure you use your idea as a clinician looking after the patient to take that decision. I remember you'll have done TOE for the patient, look at the valve vegetations, everything is clear, no problem, fever is down, patient is very well, up and doing, there's nothing to suggest complication. So as a clinician, you could take that decision at that time, whether you want to step down to oral antibiotics or not. Thank you.
Wow, thank you so much, Dr. Kweki. We're so grateful. So may I call on Prof for further contributions and to continue from here. Prof, sir. Hello, Prof. I don't know if Prof is around. Okay, I can't find him again. Okay, so thank you. I think we have another comment.
Prof ever?
Yes, I saw. Yeah. I saw him just recently on the call. Well, I don't think he's around again. So thank you so much again, Dr. Kweki. And thank you everyone for coming. And sorry we extended the time by 10 minutes, but I believe it was worth the time, the interactions and the discussion, especially for those going to exam. So just a few announcements. I'll be discussing with Dr. Allison. Please. Okay, Prof is now around. The Prof. Hello, sir. Hello, Prof. Prof, sir. He's a co-host, so Chief Kweki. I don't know if he's around. If you can make some few comments before we.
Okay, so I think I appreciate everyone for showing up. We had up to 42 in attendance. That's a good number, and that's the spirit. If we really commitment, we can make this platform a hub of knowledge where we can discuss a whole lot of issues. So we've started the guideline-based discussion. We hope we're going to sustain it from next week, and other aspects of cardiology will be discussed. So let's keep up the spirit. Let's look it up and let's keep our mind open. We'll make the announcement as time proceeds and see how it goes. So thank you so much for coming up, and God bless everyone of us.
Thank you so much, Dr. Kweki. Thank you, everyone. Please for coming for this presentation.